Hello, everyone, and welcome to our meeting this morning. So the topic for our meeting this morning would be on improving substance use disorders treatment series. So this is the second part of this, I believe, 10-part series. And then the next one is scheduled for October 23rd, I believe. Again, thank you for joining us this morning, and then I'll be passing over to Kelly Feenstra, who is our program specialist at the MPCA, so we can get started.
Thank you, Derek. Thank you everyone for joining today. We have a great presentation from MPCA's data team about using data collection for quality improvement. Our speakers for the day will be Cheryl Gildner and Beth Holt from MPCA. They have great experience in this, and we are very excited to have them. And with that, Tom, did you have anything else to add before we start?
No, just very excited for today's session. And actually, I'll simply say the session after this is October 23rd. That will be Dr. Juni again, and we'll be focusing on the use of buprenorphine in OUD. So looking forward to that session as well.
Yeah, very excited to have you back. Yeah, so with that, Cheryl and Beth, you can take it away.
Thank you. So this morning, we'll start with how we can use data in Azara for quality improvement and what options there are. Our session objectives today are to identify the data available in Azara, understand the ways to utilize the data in Azara for quality improvement, how to integrate SUD data for whole person care, and using the data to identify some patients at high risk. Just as an overview of our 30 health centers that are on Azara, 26 of them have implemented the controlled substance module in Azara. This has custom registries, reports, scorecards, and dashboards that allow for some different data collection. So in looking at some of these options in Azara, with that controlled substance module, the idea is it provides early identification of patients at risk for alcohol and substance misuse. You can track and manage these high-risk populations and high-risk medication use, along with assessing some of the impact of education and changes that you may make to your workflow. So the first part of some of the substance module is looking at some of the measures that they have. So there are quite a few measures, and Azara has broken them down into 4 categories: substance disorder and prescription, medication management, initiation, engagement, and retention and treatment, and then lastly, the prevention and screening. So these 6 measures on the screen all focus around substance disorder prescriptions. This category looks at the medication management of it, and there's a newer measure that came out earlier this year, and that is around the diagnosis of an opioid use disorder and having a naloxone prescription prescribed within the last 12 months. So if you already have this module at your health center and it's not showing any data, it may need to be mapped, or any of these measures. If you notice any of these measures are not mapped correctly or the data doesn't seem right, submit a ticket. Based on workflows, the mapping may be a little different for each center. These measures are around the initiation and engagement. So it looks at how many patients started treatment and initiated that, and then how many of them continue to engage and throughout the treatment. And then lastly, the prevention and screening measures. These are kind of looking to identify those high-risk patients early. And so there's 6 measures that focus around this category of measures also. Once you've taken a look at some of the measures, next what's available is there's reports through Azara. You can always make your own report. This one has already been built out, this controlled substance report, and this has all of the measures we have seen on the previous slide all pulled into one report for you to look at. So you can individually select a measure from the report or from the measure analyzer that we talked about in the beginning. If you ever want more information, you can select this detailed list, and that provides a ton of information, ranges from the opioid prescribed, the start and stop date, when it was filled, the numbers of refills. But new to this is the prescriber column, and so that tells you who prescribed that opioid. So that's a good tool to have also. There are also registries in Azara, and these provide a ton of detailed information. There's some custom ones that you can make, or there's these that are already in there. This last one on the bottom, the MPCA SUD Innovations Grant Quarterly Report, this was built for a grant, but it can be used by anyone. And this includes patients of any age who have had a medical encounter or pending appointment in the specified time frame, and buprenorphine, methadone, or naltrexone treatment during the treatment period. It will include the diagnosis, the current treatment, key lab data, and patient's assessments. So you could always copy this registry or any of them and rename it for your own center, and then include or take out the things that you don't want to see. This registry, the Opioid Medication Potential Misuse registry, is also a good one to look at. It includes different information. It looks at some social determinants of health are included in here. But this one also includes the drug screen and what they've tested positive for. Always remember that if you're prescribing opioids for someone, you would anticipate them testing positive for opioids on a drug screen. They wouldn't test positive for other things like amphetamines. There's also alerts. So if you have, I'm sure many of you have enabled many different alerts that populate on a PVP, but ones specific to substance use in Azara include one on alcohol screening. There's a controlled substance agreement one. There's one around drug screening, and then also substance use screening. You can enable them for your center, and depending on how you utilize them, they may show up with different names on your PVP. So for example, this alcohol screen, it's the same alert, but it shows up differently on different centers' PVPs. And just as a reminder, this is what it would look like on your PV, or this is what your PVP would look like, and those alerts would populate there if they were missing or needed to be completed. We have a new alert coming, and this one's being created with MPCA and Azara, and it will be around if the patient has had an opioid prescribed in the last 90 days, will be a new alert that can be populated also for the PVP. Another way to collect and show data is through the use of a dashboard. So this one has already been created. The MPCA Substance Use Dashboard has a ton of information on that. So how many patients have been screened for substance use disorder, how many have opioids on their med list. There's a ton of information in here. It's a great place to start and have it all pulled together. You can, again, copy it, make it your own, or create one yourself. Then we have one specific to buprenorphine, and this one's broken down by race and ethnicity, gender, and payer. So if you want some more detailed information about your patients that have a prescription for it. Same with naltrexone, there's one for that as well with the same information based on gender, ethnicity, payer, and race. Your last resource as a way to collect data in Azara would be using a cohort. And so you could, for example, if you selected the opioid use disorder treatment measure and you clicked on the detail list, you'll then see 3 little dots in the upper right corner, and that's how you would create a cohort. This creates a working patient list. So you would create this cohort, and then it's a list that you can work off of if you're trying to identify patients or patients that you need to contact or get in. This is a good way to do that, and you can save the cohort right to Azara and continue to pull it up. Cheryl's going to talk next about how you can utilize this different data in Azara.
Thanks, Beth. So now that everybody's kind of familiar with what tools are in Azara to use relative to substance use and working with that population, we're going to kind of take a deeper dive into how you can use some of those tools. And if you want to hit the next slide. To me, looking at this tool and being in it and using it, cohorts and registries, but cohorts is one of the most powerful tools that's in here. And, you know, we have some centers that have made a ton of cohorts. It just, you know, it really allows you to hone in on a population and manage that group of patients. When you look at a denominator for a measure, and even if you look at the gap, so people not meeting the measure, you can be in the upper hundreds or thousands of patients. That, I don't know about you guys, but to me, that is too many patients to manage. We never had the resources to manage that many patients. So I'm not sure that other people do, but so if you can break them down by certain criteria into smaller groups, and you can define, you can slice that a million ways and figure out how you want to break those groups down and then create those cohorts. I would suggest when you create a cohort to be as descriptive as you can in the naming of that cohort. So when you're using it, especially if you have multiple SUD patient cohorts, we've seen people label them with the date so they knew that this was the group they created on 8/1 of 2020 or something like that. Just so you can kind of keep track of who's in that cohort, you can be fairly descriptive in the naming of those cohorts. The one thing about cohorts is out of the box, they are a manual cohort. You move people in and out of that cohort. So there is some management involved in that. Azara does have dynamic cohorts available. Of course, there is a small charge for those. And if you're interested, let us know. But often you can get that cohort unless you have large programs where managing it manually isn't really all that feasible. Most of the time you can manage them manually, especially if you have care managers working with those populations, with those cohorts, because often you have a group of patients assigned to a care manager and they can then manage their cohorts in Azara rather than on that Excel spreadsheet that y'all have on your desk. So, being able to create those cohorts and then use them as a filter. The difference between the dynamic cohort is you really have to have clear criteria for moving people in and out of a cohort, and that's often a little squishy. So sometimes creating those dynamic cohorts can be difficult. Also, we had a center that in their manual cohort process, they wanted to keep track of patients. So they had a process of active engagement and then kind of graduated. So people who completed the program, but they wanted to keep track of those folks as well. So they created the active cohort. And then as people completed the program, they put them into what they called the graduate cohort so that over time, they could continue to watch those patients, but they were at a different level of intensity for their care management program. So, the active folks were getting pretty intense follow-up through care management, but the graduates, they just wanted to be able to track them over time and maybe do a check-in once in a while. But it's a great way to not lose people in the cracks, Did somebody have a question?
I have not seen any in the chat box.
Okay.
Yeah, not here.
So once you create those cohorts, like I said, you can use them in reports, registries, and we'll look at a couple different ways that you can use that cohort once you've created it. You can go to the next slide. Transitions of care. If you are a Michigan Health Center, you have transitions of care that is using Azara, flowing right into your Azara application. A lot of people are used to going to another source. If you're already in Azara using it, it's the same information. We have a direct link with MyHIN, and so that ADT that's going to other sources that you might be used to using is flowing that same one is flowing right into Azara because we created that direct link with MyHin. So this is a place that you can go and look for information on this population. You can go to the next one. So when you go into your transitions of care, again, you can go, there's a column called description. And we do have some limitations here, and we're working as hard as we can with hospitals to give us more information because we do have some hospital systems that are not sending discharge data. And it's not just us, they're not sending it to MyHin, so there's no data there to grab. It is really difficult. And when you talk about follow-up for PCMH, if you've got 100 people that were in the ED and you have to do follow-up, you don't know why they were in there. So that's a lot of people to follow up on if they were only in there because they broke their finger and you are looking for COPD, were they in for some complication to their diabetes or COPD or an MI or something. You're probably not going to follow up on a broken finger, but we sure would like to know that information. But you can look and see if you had folks in there for a substance use issue. And if you go over to description or code, if you know your codes by heart, you can sort by, like I just put in substance, and those are all the things that came up. And these were folks that had an ED visit in the time period that I selected. So, these may or may not be people in your MAT program. They might be some of your other patients, and you may not even have an SUD diagnosis in their chart on them, but if they're showing up at the ED for a substance use issue, that's probably something you're going to want to follow up on. You can go to the next one. Again, if you create those cohorts, you can look at that ED or inpatient transition of care report by your cohort. So you can look and see where any of my cohort folks, maybe you have a SUD high risk group, and you want to run it against the ED report. In this report, you can see number of visits in the last 6 months. If you have frequent flyers that are visiting the ED often, maybe you put them and they're in your SUD program or something. Maybe you put them in a cohort so you can see how often are they going to the ED, and then you can run it against the inpatient report. Are any of them admitted, or are they just going to the ED? So you can see all of that information in those reports. Next slide.
Cheryl, we have one question.
Okay.
Is the TOC limited to acute care facilities, and does it have information for mental health inpatient facilities?
Everyone who sends data to MyHin, we are getting it. So we are getting from long-term care. I'd probably have to know the name of an organization to look and see if we're getting like crisis care, like a CMH crisis intervention. I don't know that they send to MyHin because of CRF 42. C397, whatever that is. So those, we would not be getting those because they're restricted on what they can send. But we can see in that report if someone was, the discharge code. So one is discharge to home. I don't know what the code is to, I think it's 5 or 7 maybe, that they were transferred to a psychiatric facility, but you can see that code in the report. So you can see if you had a patient present to the ED that was then transferred to a psychiatric facility.
Thank you. And the example they sent over was Pine Rest.
What was that?
The example they sent over was Pine Rest. Do you know if that one is in there at all?
Okay, I believe I have seen Pine Rest in there, but I would have to check. Yeah, you can look by, so the facility, sending facility, or the place that they went to is also listed in that feed. So you can sort by, you know, if you have particular hospitals or facilities that you work with, you can sort by that as well. And you can look back. So if you want to do you set the date. So if you want to do, it automatically gives you, I think, a weekly view. That's the default period that comes up. But if you want to look back 3 months, 6 months, you can do that. And then it also tells you if they have an upcoming appointment already on the books. One thing that I have looked at just to see, because in theory it exists and I know it exists, but I wanted some data to prove it, is how many people missed their last appointment at the health center, like it was a no-show, and then within often the same day showed up at the ED, and then do they have a follow-up appointment already scheduled at the health center? So you can kind of look and see, you know, of the folks that showed up in the ED tonight, how many of them had a no-show relatively soon before that presentation in the ED. The risk stratification, if you are not familiar with this, this is a pretty powerful tool. This was designed for the state of Michigan by a committee that we put together of your peers, medical directors, some quality folks, I forget who all was on that. We had about 3, 4, some nurses, some care managers, different disciplines engaged in the committee. It's based off the Johns Hopkins model. However, it is not, and it is separate because the cost of using the Johns Hopkins model would take most of our budgets for the year. So this is the next best thing. And every patient in your EHR, regardless of age, is run through the risk algorithm and assigned a risk. And it's based on a lot of different criteria. And if you haven't been in here yet, the first widget on the far left-hand side, you see all those little boxes coming out of it because it's a long box. There's a lot of information, but that is all of the things that make up our risk score, a person's risk score. So it's based on not just physical diagnoses or medical diagnoses. It is based on behavioral health diagnoses, substance use diagnoses, out of range labs or vitals, high risk medications, social determinants, inpatient and ED visits. We tried to make it as comprehensive as possible to drill in on who is our high risk. And it certainly is not just people with medical conditions. For those folks on the call who work in behavioral health, you know that those tend to be the folks who have some of the biggest complications. And it's not really their medical issues that are complicating what's going on with them. So if you look at, like, the one on the top is diabetes, and you can see that the patient count, so that's looking at how many patients have that diagnosis. The prevalence is what prevalence of your population has that diagnosis. Percent high risk means how much of what is the percent of your high risk patients that have this condition? And if you look at this chart and you filter that percentage to the top, it really is the cardiac conditions that tend to make up most people's high risk. But then you see the points score. So for each individual item, a patient is assigned points. So if you have somebody with diabetes, hypertension, and substance use disorder, they have 5 points right there. If they also have depression on top of that, that's 6 points. So you kind of look at a patient and go down that scorecard. And then once you get a total score. You take it all the way over to the right-hand side, and based on their age, they're assigned a risk category. And you'll notice that there's different levels for different ages. If you have a child that scores higher than 5 or 6, they're high risk. Now, there's not much going on with kids, chronic disease-wise, so you would not expect to see high scores with kids. So that's why, you know, you look at those scores for pediatrics, and they're fairly low. So for somebody to be in the high risk category, if they have a score of 8 or higher, they are high risk. If you take that same number and move it to the next age group, you know, an 8 puts them in the low category, but a 9 puts you in a moderate. So, you know, that is the age category where you tend to have the highest number of uncontrolled conditions, and that's where those values come in, looking at not just the chronic disease, but the lab values. How far out of range is that BMI? Is that blood pressure? Is that A1C? The more out of range, the higher points that are assigned. And then when you get to the geriatric population, you know, you often see better control in the geriatric population, but you see more chronic disease. So there's a little bit of adjustment in points for that. And then there's one on the bottom that says rising risk. Obviously, we're looking at the entire population. You would not expect to see almost 4,000 people with a rising risk, but that means if you, from the last time that person's risk score was calculated to today, their risk score went up. So it's a really good way to monitor, do I have patients with a rising risk? It either means they've had, you know, a new diagnosis, their numbers are out of whack from last visit, they've had a ED or inpatient visit or more. So that's kind of a clue for you to look at who are those folks. And obviously you can click on that number and go right to it. Usually I don't see, if I look at a single center, it's rare to see anything higher than a 8 or 10 or somewhere in there, but sometimes you get, you know, a 50 in there. And then the widgets in the middle, you know, it just shows you the breakdown. You can sort this by provider as well. You can sort it by your like I said, your cohort. And it gives you your total number of high-risk patients, and then as opposed to the total number of patients. You can go to the next slide.
Yeah, we have one more question. Does Azara provide recommended search criteria to identify admissions that may be related to those at risk or with SUD?
Recommended search criteria. Somebody, oh, you mean in the, so what, in that description in the transitions of care?
I think so. Tom, do you have any clarification on that?
No, I think Cheryl's spot on.
Okay, so I have looked, substance, starting with the word substance tends to be the most used. I have started with opioid. I have started with overdose, accidental overdose. There are very few that come in under different headings. So it seems like for our hospitals in the state, that diagnosis that it contains the word substance is the one that's going to get you the majority of your patients. You can try some of those other ones just to see what's in there. This one's pretty clear cut. Let me tell you, if you're looking for your dental folks that were in the ED, it could be anything under the sun. So, but if you're looking for, you know, substance use related inpatient or ED visits, that's a pretty good bet to use the word substance in the search. Some more on the risk algorithm. Like I was talking about using your cohort in here, you can look by patient diagnoses. You can check what does my risk profile look like for my patients with a substance use disorder and a behavioral health condition. So you could put both of those under patient diagnosis. You can search by your cohort. If you are using care managers, that will pull into Azara, and you can search by just your caseload. So how do my patients look? And this was obviously filtered down to a single center because the numbers are a little more reasonable. Actually, we sorted this one down to a cohort. But if I'm the care manager, I could have selected my name out of the drop down, and I'd just be looking at my patients. So I have 65 patients on my caseload. 13 of them are high risk, and 2 of them had a rising risk. So all of those numbers are hot numbers. You can just click on them and go to the patient list and find out who those patients are. And obviously it gives you more detail when you go to that list. It will give you what their risk items are. Each column will show you what their risk level or what their risk identifiers are. Also, if you look at, so when we're looking at a smaller group, if you look at that risk distribution, it's all over the place. It doesn't have a nice curve to it at all. Because when you're looking at a smaller population, you're better able to pull out those that look at individual risk that isn't drowned out by the other 2,000 or 5,000 patients that you might have in your organization. You can go to the next slide. So on the left, that overall risk distribution, if you look at your entire population, that's what it's going to look like. That nice little curve, everybody's kind of bucketed into lower risk categories, and then you have a few in that high risk category. Those high risk categories look so small because you're looking at such a large population. This other one is the distribution with a filter applied. So if you're looking at a smaller group of patients, you can get a better look at how many risks that individual group of patients have. And you can see the majority are between like 6 and 9 risk factors. You can also see that you have a pretty significant group that have 14 or more risk factors. And that's probably the group that you're going to want to hone in on first and see what's going on with them. Next slide. So another thing I wanted to touch on is being able to use these tools for compliance purposes. And there's a couple things built in, and if you haven't mapped this, put in a ticket because you can map it. If you are, if you have an interface, and I don't know what I know it as maps. I know it has a new name these days, but if you have done the state interface with maps, you probably have somewhere in your EHR that you click on to check it. Or if you're still going out, logging in and checking it that way, do you document that anywhere in your EHR? If you do, get that mapped to Azara so that you can check it. This is a good compliance check. If you ever had to, if you've ever had to defend yourself in court for a substance use related issue, you want to make sure you have documentation that the system was checked, that you were following. I forget when it went into effect, but if you are looking at your policy, have you updated it to match Laura's new requirements, state of Michigan requirements? So this is just kind of a, you know, make the process part of your quality improvement. Because compliance, processes related to compliance can become very important if you ever need them. 9 times out of 10, you don't need them, but if you ever do, you better make sure you're prepared for it. The other thing is the controlled substance agreement. If you have anyone on a controlled substance, you more than likely have some type of pain contract that they have to sign, or controlled substance contract. And it generally will lay out the rules for being on a controlled substance. I, as the provider, will do this, this, and this, and you, as the patient, agree to do this, this, and this. Often that agreement is going to talk about random urine drug screens and things like that, you know, what the process is if the contract is violated, what your refill policy is, those types of things. Those are all kind of process related things, but they are part of your quality program. So make sure that those are reviewed on a regular basis. And if you haven't mapped them to Azara, again, they can be mapped. And Beth mentioned earlier, this is an alert you can enable. You know, I know one of the things we struggled with is making sure that they got renewed every year. And more than once, I would find someone would have a complaint and I'd go look in the chart and, you know, there wasn't much we could do because they didn't sign a new pain contract and we continued to prescribe that opioid without a current contract in place. So just something to think about. Next slide. Also, there's 2 new reports under the Controlled Substance Report tab. If you haven't seen these yet or played with them, you can look at caseloads. So if you have specific providers doing MAT, and this is actually a great data hygiene tool too, but those prescribers that are doing MAT, you can look at their caseloads. Do they have the resources? You know, if you have a provider that's managing 100, 200 or more patients, do they have the resources to appropriately manage that many patients? You might want to look at, you know, if a lot of places only have one person that's been waiver trained and that individual gets all the SUD patients. What does their schedule look like for primary care patients if they're also doing, you know, if they're dual duty providers? Do they have the capacity to continue at the same level of primary care, providing primary care, if they're managing a large number of MAT patients? So this is a great report to be able to look at that. You can look at it. If you don't put a filter on, it's going to bring up all your providers. If you do, if you want to look at a single provider, you can look at that. So just letting you know that this one is there. Next slide. If you're doing care management, so if you are assigning care managers in your EHR, you can get that mapped over to Azara. If you're not doing that, or if you don't have, I think part of the challenge with this is that some places have care managers that do, so a patient might have a couple care managers. They might have a behavioral health care manager within your system using the same EHR. They might have a primary care manager. They might be part of a MAT program that has a separate set of care managers. You can only choose one, and that's one of the limitations. That is where cohorts come in handy, because as a care manager, I can make a cohort of my patients. But if you are assigning a care manager in the EHR and that comes over, you can look at any of these reports based on care manager. Next slide.
So we have one question on this slide. Will this MAT report show the last date of contact with the patient in addition to the number of patients?
This one will show, if we look, oh my gosh, it's a slide. I can't take my mouse and slide over. Oops, I was gonna slide over the spreadsheet. It shows most recent visit. You can go in and change this or add a column, because I don't think out of the box, this one I think has only UDS qualifying or most recent primary care visit, but you can add a header that pulls in any kind of visit. So you can add a column and it will pull in whatever that visit was, whether it was billable or not, whatever the most recent visit is. Now, if that most recent, you can actually add a column too to just look at behavioral health. So you can see when their most recent behavioral health visit was. You can see when their most recent primary care visit was. And then you can look at their most recent encounter. So regardless of encounter type. Hope that helped. So from a quality monitoring standpoint, we had this one for a project we were doing, but you could do it between providers, you could do it between care managers, you could do it between patients who agree to be part of a treatment program and those who did not engage. So you look at those who started a treatment program versus those who declined it, or you could look, based on risks. So they're all in my treatment program, but I have one group that's high risk and the other group are not high risk. They're either low or moderate, and see if they're getting the same intervention. Do I have different results from one group versus the next? So this was done all with just by adding filters. And we're looking at the same measure, just looking at two different populations. And you can see, the centers that were participating in this initiative had a considerably higher outcome than those who didn't. So it's a great way to be able to look at, is what we're doing making a difference? And by creating those groups and then monitoring the difference between those two groups or multiple groups, you can kind of gauge what's happening. And then you can dig in a little deeper and see, either why do we think we're making an improvement here? So maybe you take your group that's showing an improvement and you divide that group even further to see what are the differences within this group. Who in this group is lifting us up, and who in this group is, could that percentage be even higher if we start dividing this group into other subgroups? And it can give you a lot of information on what's working for what populations. Next slide. Know your definitions. When you're working in here and all these hundreds of measures, you push that little I button and it gives you the exact criteria for that measure. So make sure you know the definition of your measure. There's initiation and engagement or continuity, whatever, of pharmacology. So that initiation has some pretty short-term guidelines. It's looking at that. If you have a new diagnosis, did a med start, did something start within, I think this is a 30-day, yeah, it's 30 days. So, you could follow those who started within 30 days. You could create a cohort of those folks and then watch them over time. There is a big difference between initiating and engaging. So if you look at engagement, it's looking further down the road. Okay, we started you on a medication. How are you doing further down the road? And then the other one, continuity, that one has a little stricter guidelines in it. So when I say make sure you're watching or you know the definition, click on those. If you're looking at your numbers and you're like, wow, that one's really small. We're not doing well on that measure at all. Look at the definition. That one has some pretty tight parameters to it. So just a reminder that if you want to see what those are, hit that I button and you can get your definition. Next slide. This is one of the dashboards we built. So this one, I was trying to get a cascade for treatment. And again, you can copy these, make them your own, do whatever you want with them. I don't believe, and I would hope that you don't edit ours that we have developed, but please feel free to copy and rename them and make them your own. So we're looking at patients with a new diagnosis, and then how many overall have an OUD diagnosis. So you're looking at new versus overall. And then if you go across the top, it's your, and I have to look at my bigger screen because I can't see. But how many do we have that we started MAT within the 30 days? And then overall, how many of your patients are being treated? And then the age breakdown. So how many young ones do I have in treatment? How many of them, or how many have the diagnosis? And then how many started treatment? And you'll see we have a 0 there. That population brings all kinds of challenges. So if people have had successes treating those young ones, boy, it would be great if you would share, because you have so many challenges trying to get kids that age, because you're not just working with the child, you're working with the parents or guardians as well. And so that is, I would say, one of the toughest groups to work with because there are so many challenges. But I tried to lay this out so that you can look at the top row is really about those new diagnoses. The next row down is looking at your whole population. And then that bottom row is really looking at some specifics within that population. So kind of the treatment guideline type things. You have a breakdown of who's on what type of treatment. And then, you know, have we done that Hep C screen and HIV screen? Have they also had a behavioral health encounter? And I don't know why I have the same one, and I have a filter on that other one. I guess I need to go in and rename it so you can tell what filter I put on that other group. But again, feel free to use this. It's a great way to get a bird's eye view of your population and what's going on. This dashboard really doesn't tell you much about over time, because other than that one trend line, because anytime you use just the number or the speedometer type thing, you are looking at a point in time. So this is really looking at like right now. If you want to see that trend line, how we've done over time, you would want to flip these over to some trend line widgets. Next slide. Managing risk. So this is another, I'm looking at the office-based opioid treatment registry. And again, this kind of hits on your compliance stuff. Beth talked a little bit about that substance use screening. So you can sort these columns. So, you know, if I have somebody on MAT, I can look at the, you know, I can look by medication if I want. I can sort by their MAT test date. So if they're on naltrexone, I want to see that as a positive. If they're on buprenorphine, I definitely want to see that as a positive in the positive drug test. And it's funny because the first time somebody said urine drug screen, or when I was working in the clinic and they said, well, we got to get a UDS, you know, I'm thinking, what does our UDS numbers have to do with this? And then they're like, urine drug screen. I wasn't familiar with clinical lingo, so I was going right to reporting. But, you know, you can look at when was their most recent drug screen and was it negative or positive? So I don't expect to see cocaine show up in somebody that I'm treating with naltrexone. I don't expect to see, you know, amphetamines showing up. So those are discussions that you can then have with your folks that you're treating. This is a risk. If you're treating somebody in an MAT program and they're coming in testing positive for, you know, barbiturates and amphetamines, and that's a risk to your providers who are doing the prescribing. So I would definitely be looking at this one. Next slide.
Cheryl, we got a comment about the dashboard that you shared earlier. And one of the participants said that it will be very useful in tracking MAT requirements for seeing patients in person before teleprescribing.
Yes, excellent use case. And then some prevention stuff that's in here. So all those folks that you have that you're treating, especially, the biggest thing you're gonna see is chronic non-malignant pain. And how many folks have an opioid on their med list? This gives you some opportunity to monitor what's going on. If they're supposed to be on a short-term treatment, you can look at this. You know, how long have they been on that short-term treatment? Do you have a group of folks that have been on an opioid for a long time and you see that the number keeps increasing? You know, they used to be on 45 and then they went up to 90 and now they're on 120. That tells me that potentially it's not working. You know, so you could create a cohort of those folks and then start looking at, do we have options with this group? Are there alternative treatments we can use? We just want to make sure we're educating them and talking to them about long-term opioid use and addiction issues and things like that. I actually have a request in with Azara to be able to start looking at some of the meds that kids tend to go on, whether they're a stimulant, you know, some type of ADHD med or something, so that we can start looking at younger age kids that are on treatments that could potentially put them at risk for substance use disorders. That isn't in there today, and we do have it in as a request. I'd like to see that come out before the end of the year so that we can start doing prevention stuff with those kids and with the families of those kids to keep them from ending up in our MAT programs 5-10 years down the road. So next slide, and I better talk faster. We talked a little bit about data hygiene, but there are a lot of ways you can use the system. If you're looking at prescribers, if you're running that report and you're looking at prescriber data, look and see who's coming in, because when you're using the opioid on a med list and sort that by prescriber, inevitably you're going to find psychiatrists, dentists, all kinds of different, you would expect to see that. But in MAT, you would not expect to see your dentist unless they're waiver trained and they have a caseload. You would not expect to see them with a caseload in the MAT registry. So just some data hygiene things you can think about to make sure your data is correct. If you see something out of place, put in a ticket, have Azara take a look, see what's going on. Next slide. So this is kind of just a workflow type of thing. Think about your workflows. If you're not getting the data that you want, if it's not being presented the way that it's most helpful for you, look at your workflow. Make sure that your workflow, if you've changed it, if there's a little nuance to it that you don't think you're picking up, get your tickets in. If you want more training for your team, let us know. We're happy to help you design the tools the way you want to use them, whether it's you want some help setting up a registry, a cohort, a dashboard, whatever. Let us know. We are more than happy. I know that many of you are stressed for resources. It takes some time. Reports are fairly easy. Registries don't take too long, but if you want a dashboard, those take time to build. So if there's something you want or some additional training for your team, let us know. We're happy to do that for you. Next slide. I think that's it. I made it. Anybody have any questions? Anybody want to share some successes that they have had using the module or using other things in Azara to work with your population? Okay, Kelly, I think we're good.
That's good. Thank you so much, Cheryl and Beth, for the presentation today. If there's anything else to add, we're still going to be looking at the chat box, and feel free to unmute and ask any questions or comments. And with that, I'll turn it over to Tom for some closing remarks.
Thank you, Kelly. As a quick reminder, I'm Tom Dahlberg, and I'm the Executive Director for the Michigan Center for Clinical Systems Improvement, also known as MPCA. We are so grateful to be on this journey with MPCA, each of you. Big thank you to Beth and Cheryl and the entire MPCA team. Today's session was so very helpful and so important to measuring and tracking impact for ongoing improvement of processes and operations and systems, and for achieving better outcomes, and as you said, Cheryl, making a difference. And it links so very well with the rest of our journey that will be going on together. Also, as a reminder, for each session of our journey together, you'll receive links to evaluations. Please complete so we can ensure we are best meeting your needs. And also, after the first session, you should have also received a survey titled Pre-Survey. That one really will help us customize specifically our journey together, because it asks you what's most important to you. And so we want to make sure that we incorporate that information, again, as we customize our approach in the next 10 sessions together. Let's see, our next session is October 23rd from 10 a.m. to 12. It's use of buprenorphine and OUD. And again, it'll be Dr. Ed Juni who will be leading that discussion. Lastly, but most importantly, thank you for what you each do each day to care for and care about your patients and families. I mean, that's why we're all here, and that's why we're partnering around this to achieve that better care. And again, we're MPCA, and Sue Voss, our Director of Programs, is also on the call today. We're so grateful to be partnering with you and on this journey together. So I'll turn it back to you, Kelly.
Sounds good. Thank you so much, Tom. Thank you all for joining. You'll get that follow-up email within the next day or two, and we hope you have a great rest of your day.